So very good morning. Thank you to Kamaljit sir and Shrikant sir and Pranav for making me part of this wonderful IC. And I'll be talking more about barrage laser. And I feel uh, when it comes to lasers, injections, there are still misconceptions in ophthalmologists, physicians. I recently had a patient whom I had done a barrage laser. He was a 10, 12-year-old child, lattice with holes. He had gone to his physician and he had said that अभी क्यों लेज़र करा लिया, वो तो 18 साल के बाद में होता है. So we need to work on these things. Why we need to know about these lasers? Because we don't want our patient to land up in a condition like this because we missed something like this. So it's very important to identify these conditions, where we have to laser, where we can afford not to laser and keep the patient in follow-up. This is a wonderful article in IGO by Dr. Ramesh Venkatesh and team about screening for these cases. This is more specific to when it comes to refractive surgery and other surgeries. So retinal detachment, all of us know, is a common entity. Around 1 in 10,000 people have it. There are a lot of factors when it comes to predisposing it. One of them being axial myopia, a very important factor. Another being cataract surgery, trauma, and of course the things that we'll be talking a bit about, that is the peripheral retinal degenerations. So I'll not go into the complexities and the pathologies of these. These are quite boring, but we'll just understand some important of these degenerations. Most commonly that we see is the lattice degeneration. The important thing that we need to know is that almost 30 to 40% of myopes will have it, and 30% of RDs are associated with lattice degeneration. So we cannot afford to miss these in our practice, whatever kind of practice we are in. So it's our indirect ophthalmoscopy with indentation is very important to identify these things. And a little assuring is that 2.8% of lattices cause RD. But still we need to understand, and 30% the cases that we see will have a underlying lattice degeneration. Another is a more benign form, which is the snail track degeneration. It is considered to be a precursor to lattice, which is a bit debatable. We have degenerative retinoschisis, zonular tufts, zonular tractional tufts. Retinal tears are quite obvious, and retinal holes are, very obvious when you see them. A very important event that we need to know about is PVD, or posterior vitreous detachment. So it is the link that is between a predisposing lesion that we talked about and the ultimate thing, that is the retinal detachment. Now it can lead to tears where the vitreous is very firmly attached. We all know where it is well attached, and it gives an access to this liquefied vitreous through the retinal bakes, and thus leading to a retinal detachment. So 10 to 15% of the patients with symptomatic PVD will have retinal tears. So we have to have a very high suspicion of retinal tears in these cases. And whenever you see pigments in the vitreous or vitreous hemorrhage, there is a 70% risk, which is a very high risk of having tears. So you have to keep these patients under very close follow-up. Keep calling them until unless you are very confident that you have examined the periphery well in these cases. And a lot of times what we see is that we are seeing the periphery and the break is somewhere near the posterior pole also. So once I had missed a case, whereas I was very aggressively looking at the periphery but missed something which was very right there in the center. So there are certain studies. These studies I've just picked up for people who do refractive surgeries. And it's very relevant to cataract surgeries as well, because these degenerations, are very common in myopia, and we have to understand as the myopia progresses in patients, these degenerations also increase. And PVD is also more common in myopes and may present at a much younger age in these cases. The laser-based refractive surgeries, there are a lot of factors that induce such things which will lead to RD. The high intraocular pressure that is there, a shock wave that comes during the laser ablation, and the rapid lowering of the IOP as well can lead to these are like mechanical stresses. Now, a lot of patients do complain of increase in floaters after LASIK, and even the newer surgeries like femtolasic may also have PVD, increase the incidence of PVD due to various reasons. So in both myopic patients, pre-op and post-operative, it's very important to screen them for these things, and lasers should be done when needed. So about identification, as I said, indirect ophthalmoscopy is the mainstay when you come to diagnose these diseases. So always refer to a retina surgeon, or I feel every ophthalmologist should be equipped to diagnose themselves as well. Now we have wide field imaging which can help us, but these are expensive right now. And so when to do a dilated exam, I think a flat answer would be always, but at least for the first visit of the patients and on an annual basis, it's must in these cases. Of course, all myopics, one-eyed patients, when you see an RD in the other eye, a patient has a family history of retinal detachment. So history also is very important in these cases. Whenever we are planning a surgery, these trauma cases and sudden flashes and floaters, and of course vision loss and all those things are there, then we have to see. There's another nice paper where they have recommendations when it comes to these by Dr. Venkatesh Ramesh and IGO. So we have to have these noted down and pasted somewhere in your OPD, which lasers should be considered and need urgent treatment. So a lattice degeneration with a hole. So whenever you see a lattice degeneration, just indent it properly and see all its edges to identify a hole if it's there. HST or a retinal dialysis definitely need a laser, and a presence of hole with a cuff of surrounding subretinal fluid, and when trauma leads to retinal breaks. So these are very important considerations which have to be lasers. There's no two way about it. There are certain lesions where we can debate whether you want to laser or not. So if there is a predisposing lesions, which we talked about earlier, with recent onset of flashes or floaters, when they are both associated together, patients undergoing any surgery or even an injection or a YAG laser, they should be lasered. History of detachment in other eye with a predisposing lesion, or I go for lasers in even benign lesions also. One-eyed patients and certain syndromic patients such as Marfan's or Stickler should also be considered for lasers. As we said before, family history of retinal detachment, if the patient is unable to visit you for certain reasons on a regular basis, and at times in mentally challenged patients, we also be a bit liberal when it comes to lasering. These cases we can safely observe a patient with a lattice who has no symptoms in terms of flashes, floaters, black dots. Lattices with no breaks or holes you can afford to observe, but keep them in follow-up. A pigmented lattice with no break is pretty safe usually, and lattice with atrophic holes are also safe, but should be observed. So the key word is we may not laser, but we need to observe them very clearly. So this in the same article they had mentioned about how the screening protocol should be in refractive surgeries. It can be extrapolated to other surgeries as well. So if a patient is scheduled for surgery, you should do a retinal examination, preferably by a retina specialist, or if you feel you are well trained to see the aura, and or if you have a wide field imaging system which you rely on, that can also be done. And if you note a lesion which requires some management, then you should treat the lesion and follow the patient for at least 14 days, for 2 weeks, and then plan the surgery. So I went through a lot of literature. That is the most common consensus that at least 2 weeks you should wait for these cases. Do the surgery, re-examine after 2 weeks, and after that things should be stable. But if patient complains of any other complaints, then you can keep the patient on follow-up. So just quickly, as my time is over, I will talk about the laser as such. So the laser helps. It is proven. There is no doubt about it. The incidence decreases from 43% to 13%. The mechanism is it generates stiff chorioretinal adhesions surrounding this lattice, and it's like a barrage. It prevents anything else from happening. We have two popular modes of delivery, that is slit lamp and the laser indirect, and both have their pros and minuses. I now do most of my lasers, even barrage, with slit lamps. It's more ergonomically and better for the back as well. Patient, I feel, is also comfortable. But there are certain cases, like a patient has undergone recent surgery or a child under sedation, then LIO would be more preferable. So the laser settings is 200 to 500 microns with power of 100 to 200 milliwatts and a duration of 50 to 300 seconds. And these you can titrate as you go on. You have your own settings in these cases. So at least 2 to 3 burns, not too wide, are recommended for this. Very important to cover the anterior margin. If not, you can try to barrage it till the aura. And indentation, always, if you find it difficult to visualize, it becomes very useful. and or you can use cryo anytime. So it should be moderately wide as shown in the image. And too intense lasers will, will lead to hemorrhages. There might be traction, which cause more problems. It is more painful, can lead to things like ARM, and at times we've seen CNVM also. And whenever you burn, there is a more, you burn it more, then treat that as a separate lesion and laser it out. So follow-ups, as I said, at least one follow-up after 2 weeks, and then you should keep the patient on regular follow-up. Just to conclude, dilated examination is a must. I don't think so that's a concern now in today's world. It's very important to know what are the predisposing lesions and to identify them and follow them up. Document these and counsel the patient well. If you have a ultra-wide field imaging, your job becomes easier. But if a patient comes with no complaint, it's very difficult to counsel them for a laser. A lot of times my patients who are educated ones want to see these weak areas which we are unable to show them if we don't have a wide field imaging system. So prompt treatment and follow-up, and I feel whenever you are in doubt, treat it and do not hesitate to refer the patient to a retina specialist when these cases are there. Thank you so much.
Thank you, Dr. Diva. And in this context, I would just like to mention that Professor H.K. Tiwari used to say that if you have laser, you must do it. If you don't know, you follow. You don't have the laser photocoagulation, simply follow these patients. Many of the lattice with holes without any symptoms, they used to say that you continue following.
Right.
So, but the things have changed now, because in the world of Consumer Protection Act, if you don't do laser photocoagulation, and by the way, if it happens, I mean, in 2% cases you get detachment, then you are in trouble. So thank you so much, Dr. Diva. Diva is practicing at Lucknow.
So as you said, informing the patient is very important.
Yeah.
So that at least they know. If they don't get it done, that's
sometimes
exactly.
laser can also give
work.
that is also there.
Yes. I've seen one of the fellow who did the fellowship from Nagpur. He did the first very case. He said that left myopics are the best case for doing the lasers. He did one very case, not laser, the cryo, and patient landed into full-fledged detachment. Improper cryo, or cryo itself can lead to it. And he left the vitreoretinal surgery. He is now anterior segment surgeon.
I think that was a good decision.
I am facing a Consumer Protection Act because I did laser. I could see the hole. I did laser. It was a big hole, and then I referred him to Lucknow for the detachment surgery, but he didn't go. It went there after 3-4 months, and by that time the problems were. So he has sued me. कि आपने लेज़र किया इसलिए detachment हो गया. So these things are there. We must get a good consent in all